The premier event for infection prevention and control is coming to San Antonio this June. APIC's annual conference brings you the latest research, innovative products, and practical knowledge to help you prevent infection. From inspiring keynotes to thought-provoking panel discussions, APIC 24 curates an extraordinary platform for knowledge exchange. Meet IPs from around the world who face the same daily challenges as you. If you work in infection prevention and control, you don't want to miss this event. Learn more and register to join us in person or virtually at annual.apic.org.
You're listening to the 5-Second Rule, brought to you by APIC, the Association for Professionals in Infection Control and Epidemiology. Together with our nearly 16,000 members, we strive to create a safer world through the prevention of infection. Join us while we talk to infection preventionists and other experts to learn the truth about some common myths related to the risk of infection and to get tips to keep yourself and the people around you safe from infection. Hey everyone, it's Sylvia. Hope everyone's doing okay. Hi Hannah.
Hey Sylvia.
How's it going?
I'm doing all right. It's Antibiotics Day, so I'm pretty excited about this one because this is the one that's been kind of all over the place between it being in your food and asking for it too much, and antibiotic stewardship is like such a big issue now, which I'm happy to see that it's getting so much attention because it's kind of probably been very frustrating for healthcare workers on the other side.
It has. I mean, we wanted to call this episode Pills, Pills, Pills. Maybe a little bit too many out there, too many antibiotics, or maybe antibiotics for the wrong reason. So super psyched for today's show. We have what I like to call one of our big kahunas at APIC, real super guy, Marc-Oliver Wright, and he's got a bunch of letters after his name, so that totally tells you he's the big cheese. And among his letters is he's a certified infection preventionist, a CIC, and he's going to talk to us a little bit about antimicrobial stewardship. And wait a minute, it's antimicrobial stewardship, antibiotic stewardship. We also talk about antimicrobial resistance, which is basically these bugs and viruses, they're way better than us at sort of figuring out how to stay alive. So they figure out how to arm themselves against some of the medicines that we take for illnesses. So we're going to get some clarity from Mark on that. Are you pumped?
I'm pretty pumped. I mean, I was flipping through JAMA because that's what one does, right?
What is that? The Journal of Medicine?
The Journal of the American Medical Association.
You got it.
And they did a study that showed that doctors are actually more likely to prescribe you medication, either if your appointment is at the end of the day, because they want to kind of get you out of the office, and they may know that you don't need it, but they're behind on the schedule and they want to prescribe it to you, even though they know that you might have a viral infection and they're about to prescribe you something that rhymes with C-snack that many people like to get when they're feeling a little under the weather. Or if I think the part of that study was also it stemmed from, I think it was judges who were more likely to grant parole at the beginning of the day versus the end of the day. So someone thought, well, I wonder if this applies to antibiotics and prescriptions in general. And turns out that it's absolutely the case.
Fascinating. I wonder if doctors actually realize that they're doing that. They probably don't.
Maybe they will after they hear this. And
Check
we're
out
like,
that
hey,
article.
no, stop doing it.
Well, and I also have heard, so for those of you who are parents out there, or even just patients, sometimes we feel better if we go to the doctor and we get something, right? You got the sniffles, you're coughing, you go to the doctor, and you don't want to hear, well, there's nothing I can give you, because sometimes getting something makes you feel better. It's kind of placebo effect, maybe. So I know that some of the articles I've read have, pointed at patients as being part of this problem, also part of the solution, right? So it's important to understand the difference between what's a virus, what's a bacteria, what the antibiotics can and can't do. So psyched to hear from Mark about this. It's This is an important episode. Anybody listening, you're going to want to share this one with your friends and family because this is big.
And maybe, I like to think of myself as an adult from time to time.
Yes, you are.
Thank you. I appreciate the second on that. Versus going into the doctor's office and, begging for medication that you don't know whether or not you actually need. Just do what I did when I was a kid. I had a little change purse and took my Smarties and took them out of the wrapper and just popped them in my little change purse. And then I felt like I was taking my pills. Maybe I'm endorsing now eating far too much candy, but I think that's a little bit better than contributing to antibiotic resistance.
Yeah. So Mark's going to clarify for all of us, patients, clinicians. There is a case to be made. They are important, and there are illnesses that we definitely need antibiotics for. So he's going to talk to us about that. So we want to introduce Marc-Oliver Wright. Hi, Mark.
Sylvia. Hi, Hannah. How are you today?
Doing all right. We're excited to hear from you about this.
So, Mark, tell the folks where you are. You're somewhere in the middle, right, of the country?
I am an infection preventionist at the University of Wisconsin Hospitals and Clinics in Madison, Wisconsin.
Yay.
So right in the middle of the Midwest and just a little north of the cheese line. So it's really great to be joining you today.
Well, thanks for joining us. So first thing off, talk to us about, maybe it's important to really start off with helping folks understand just briefly the difference between a bacteria and a virus and when, antibiotics are for?
They're for bacteria and bacteria only. Yeah. So when we're looking at antibiotics, it's for a lot of us that we've, grown up and lived in an era of, great health, seeing our increases in life expectancy. And that really can be probably brought down to a couple of really radical changes in the last 100 years or so. And the first being the advent of vaccines and preventing, childhood diseases that were once fatal. And then the introduction of antimicrobials and specifically antibiotics. So we've had this luxury existence for a while where things that would normally wreak havoc and have a mortality rate are now treatable. But the problem is that almost from the get-go, when we introduced the use of antibiotics, the bacteria have outsmarted us. You have to think that the bacteria have been around before humans. Chances are that they're going to be here after we're gone. And the reason is they're incredibly adaptive and able to resist efforts to undermine them. And the growth of the antibiotics in the antibiotic era was really a good gut punch. And when people started talking about the end of infectious diseases as we know it, and there would no longer be a need for infection preventionists even, because we would just wipe out infection. And of course, what we saw is that as we would develop an antibiotic, we would introduce it would work for a while, and then we would develop, or the bacteria would develop a resistance mechanism to it. So
and by
when we're looking at the
antibiotics,
we're really looking at antibiotics used specifically for bacteria and not for viruses. And that's especially important in the winter months when you have these non-specific respiratory infections. Could be pneumonia, could be an adenovirus. All I know is I feel lousy and I want to feel better.
Right. And so you were saying these protective mechanisms, those little bugs are out there trying to protect themselves. They've got the armor. They've got, I'm thinking, the knight with all the metal stuff protecting them against this antibiotic, which is trying to kill them. And they're like, hey, I just want to be alive.
Yeah, it's almost like a chameleon effect, right? So as you introduce an antibiotic, let's say it's a green pill, suddenly the bacteria say, well, I'll just turn green and that way you can't find me, right?
Wow.
So it's sort of a hiding in plain sight approach. And the issue here is that not only is it important to use antibiotics appropriately, the costs of doing so of not doing so really are not just at the patient-specific level, but it's really at the societal level, right? So when we develop new resistance mechanisms in bacteria and make it harder to treat, those organisms can and do can be spread to other patients who no longer can benefit from the antibiotic that it once was susceptible to. So you can see inducible resistance in general increase over time.
So let's do some, we'll put our education hats on for a second. Let's do some infections 101 here. What are some common viral infections and common bacterial infections? Because I think that's a great place to start. Because if we started immediately saying bacterial is only treated by antibiotics. Antibiotics will not help for viral infections. So let's teach our listeners, what is a viral infection? What are some examples of bacterial infections? So you know that if you've been tested and test positive for a viral infection, don't be asking for that C-snack, and because it's not going to work.
Yeah, so that's great. Some of the best examples really are found with respiratory viruses. So there's viruses like influenza, commonly called the flu, which is different than what people call the stomach flu. So influenza is infiltrating your lungs. The stomach flu can often be a result of norovirus or other gastrointestinal viruses that give you signs and symptoms of gastrointestinal or GI or upset stomach or diarrhea. Those are some of the best and easiest examples to sort of work your way through. Other viruses usually have virus in the name, like respiratory syncytial virus or RSV, which can really wallop the little kids, especially towards the tail end of a winter season. And then for bacteria, probably the best one, it's not the best one because there is no great bacteria, but the best or most common example that comes to mind is really straight up strep throat. Strep throat is caused by Streptococcus as a bacteria, and that is important that if you do have strep throat, it does need to be treated. If you don't treat it, it can actually cause you more problems outside of the immediate problem of just having a sore throat. It can actually develop into a worse and more systemic infection. So really, it's when we talk about antibiotic stewardship, we're really talking about the right drug for the right bug for the right time or the right person.
I think you should say that again, Mark.
Sure,
I really do, because that's important.
So yeah, antibiotic stewardship is really the right drug for the right bug for the right person or the right time.
Love
right?
it.
So each of those is really important, right? So you want the right drug. You want the antibiotic that is effective against the bacteria that is causing your illness. So, for example, if you have a drug-resistant bacterial infection, like we've mentioned, that can develop, like an MRSA or methicillin-resistant Staph aureus, and then obviously you don't want to receive an oxacillin therapy or an oxacillin antibiotic because that's not going to treat that infection. And the right bug comes into play because you want to make sure that you're actually treating a bacterial infection and not a viral infection. And this is where you get into the discussion of patients wanting antibiotics or prescribers getting towards their end of the day and wanting to get on with their day. And then for the right time or the right person, sometimes patients can have bacteria and not actually be sick from it. And a really good example of this is as we get older, people can often develop what's called asymptomatic bacteriuria, which is a strange term to be using, but what it really means is that somebody has bacteria in their urine, but it's not actually making them sick. It's not a urinary tract infection. It's just bacteria that's in their urine. And if you give an antibiotic for that, even if it's for the right organism that you cultured, you could actually set the person up for a worse infection, because every time we give or use antibiotics, we're also getting rid of some of our healthy microbiome that helps, sort of instill this symbiotic balance in our bodies where you might develop something really bad like a Clostridium difficile infection because you were given and took an antibiotic that you didn't really need at the time. So the right drug for the right bug for the right person or right time.
So Mark, yeah, that's really helpful because I think a lot of people, well, first of all, like you said earlier, that, the bugs and viruses, they've been here longer. There's way more of them. But we are also made up of a lot of those bugs. And it is about balance. And one thing I want to touch on, because again, it's not just patients out there listening, our colleagues, our doctors who are just trying to do the best thing they can. There are some common illnesses that had typically been treated with antibiotics, but now there's a new message. And I'm thinking of things like rhinosinusitis or, uncomplicated bronchitis, or what's a cold, what's an upper respiratory infection, pharyngitis, like you said, a UTI or a urinary tract infection. Historically you would get the PAC. And, now there's a whole new thinking. And I think our physician colleagues, they're doing the best they can, but it's also a shift in culture, right?
Absolutely. And it's a shift out of necessity, right? So first of all, when we were using those antibiotics, it didn't really work very effectively or very much of the time. But it was an opportunity to give a patient something that makes them satisfied, in the sense that this disease is more likely to normally run its course. But if I give you an antibiotic, it makes you feel like I've helped you. I mean, and this is a really compromising position for our providers to be in. And, I've got 2 young sons. They're 5 and they're 8, and they are just the most, rambunctious, get into everything kinds of kids you can imagine. And it's funny because I've gone through that stage of where it's late night and your child is screaming and it looks like it's an ear infection. This is a really good example because the American Academy of Pediatrics has some very explicit directions about when you should or should not use an antibiotic. And I've been in that position as a parent, even with knowing, antibiotics are not going to help this situation. They should not be getting antibiotics for this. And at the same time, at 3 o'clock in the morning, I'm thinking, man, I wish I had some antibiotics. So it's really it's an unfortunate position for both the patient and the provider. But really, if you're looking at this from an evidence base, what is the right thing to do? So the best thing for providers is to know what's going on in their community, right? So if you know that influenza season is, way up, or has already kicked off and is climbing steadily, and you're seeing a lot of patients coming in presenting with non-specific respiratory like symptoms, you can probably say this is probably less likely pneumonia or bronchitis and more likely influenza, and therefore it needs to run its course than you would say in the middle of the summer, right, with someone coming in with the exact same symptoms. Somewhere in the northern hemisphere, I should specify, right?
Right.
So providers need to understand and know what's going on in their community, in their setting, and they can do so by getting that information from their affiliated infection prevention programs, because we're tracking that. We're looking for that uptick in influenza-like illness because we're putting patients in isolation when they're hospitalized. So we certainly have that information. Is flu coming? Or your state health department is usually issuing a report about once a week at this time, or at the influenza time of year. They'll send out a weekly report saying how many cases of influenza and other respiratory viruses are occurring. So you can have a sort of a background information going on, before you even set foot into the exam room. And then for patients and for the public, it's really an understanding and awareness that, maybe the antibiotic is actually not going to make me feel better. I want treatment. I want to feel better, but that doesn't necessarily come in the form of an antibiotic. And just from a pure parenting anecdote point of view, I've gone through this experience myself, again, with the example of an ear infection where my spouse was taking our kids to the pediatrician, and she said, "Do you have any?" I wasn't able to join her, and she said, "Do you have any advice or anything you want me to ask?" I said, "The pediatrician is going to tell you they have an ear infection. They probably do. If they try to offer you an antibiotic, refuse it. Ask if there's any, sort of pain relieving therapies we can try at home to sort of help us ride through this." And that's just coming from a very, obviously a different background. And it's a tough conversation to have because, again, at 3 o'clock in the morning, all you want is your kid to feel better and for you all to be able to get some sleep. But sometimes that answer is not going to be an antibiotic. And sort of having that approach, I guess, when you're going into the exam room, or you're whether you're the provider or the patient, to go, what is the best case or the best situation for this outcome? And then it's really on the provider to help educate the patients, which is something that needs to be done in terms of, what is the likelihood that this is bacteria or viral? A lot of providers have gone with the approach of, let me write this prescription for an antibiotic and take a culture. And when I don't fill this, and then tell the patient, don't fill this until I call you or unless I call you. The idea being that, sometimes a diagnostic test is necessary to differentiate a viral versus bacterial infection. Not always, but sometimes. And that, of course, takes a little bit of time. And this way, by giving a prescription signed and ready to go, if it comes back as the most likely bacterial suspected candidate, the patient can fill that prescription at that time. And at the same time, if it comes back viral, they can notify the patient and say, don't fill that prescription. Don't take those antibiotics. Here's what you need to do instead.
Oh, that's great advice.
And I think, one of the other points that we were thinking of is those rapid diagnostic tests that you're talking about right now. I mean, that is part of what we're trying to, what the medical field is trying to provide to those providers on site so that they avoid these issues. I know I was at going to see a minute clinic or one of those urgent care, and I was convinced I had strep throat because, when you have a sore throat, your immediate thought is, I must have strep throat. And so I went, assuming I had strep throat because I've had it before, and they did the strep test and they said, you don't have strep throat. And so in my head, now that I am more aware of antibiotic resistance, and I walked out with some mouthwash that numbed my throat because, the pharmacist was insistent that this is not a bacterial infection. I'm not going to give you an antibiotic for it. Unfortunately, you might just have to wait it out. And I kind of shook her hand and I said, I am exposed to infection prevention practices on a daily basis. It's my job. And I just want to thank you for being a part of this whole stewardship program that we're trying to achieve across the medical industry and making sure that we are accurately prescribing.
Yeah, and I'm glad you mentioned pharmacists because they are key to the antimicrobial stewardship team and movement, if you will. And the other thing, Mark, I've heard, certainly through our work, that this is also something that the veterinary world is looking at. Animals, they get antibiotics. Oh, yeah. So there's a big push to educate and work with our veterinary colleagues. And this is something that blew my mind, Hannah. I don't know if you knew this, but there's an issue with how we manage antibiotics in not just the animal and human world, but how we dispose of them. There's evidence in some countries where antibiotics are getting into the water supply, and so that's impacting us in our food. So this is kind of a worldwide challenge. I know that the Centers for Disease Control have issued an AMR, an antimicrobial resistance challenge, and it's looking at all these factors. So it's huge.
So that's all the more reason not to go to your doctor and, push for medication that you don't need, because there are other factors currently in play that are also contributing to this resistance. So not only are you asking for the pack, you're then potentially getting it through your poultry or through other meat that you're consuming on a regular basis. Potentially, it sounds like through your water supply as well. So stop asking for it unless you really need it.
And that's not to say that there aren't issues or diseases that do require, as Mark was telling us,
absolutely,
the right antibiotic for the right patient bug at the right time for the right duration. And, that leads us into asking Mark, hey, Mark, what's bugging you about this antimicrobial stewardship conundrum? Tell us one thing that's bugging you.
Yeah. So, I think the interesting I've been doing infection prevention for almost 20 years. And pretty much since I've gotten into this field, I've been hearing the siren call of the antibiotic era is coming to an end, which, when you hear, sort of the town crier shouting, the sky is falling, eventually you don't get so worried about it. But I think there have been a couple examples over the last, say, 10 or 15 years of bacteria that are resistant to all the antibiotics that we have available. And then at the same time, the pharmaceutical industry is not getting in the business of developing new antibiotics. And for a couple of reasons. But the first one is they've kind of figured out it's often a losing, from a financial sense, it's a losing proposition, right? I create an antibiotic, I go through the trouble of developing one, I go through the animal studies, I go through the human trials, I get the FDA approval, it's ready for market, I market it, I put it out there, and then within a very short time period, the bacteria that I was targeting with my brand new, wonderful drug is suddenly resistant to my heavily invested development.
They've got their shield protectors on.
Yeah, they put their shields on. So we have a couple of things happening simultaneously. We have a bacteria that have developed greater and less well understood resistant mechanisms of an evolving nature. So we're getting tougher and tougher bugs with more and more armor on them, and we have a diminishing supply of new antibiotics coming to market. So this whole idea of an antibiotic era coming to an end, I hate to say it, that's what's really bugging me. That it actually is a real possibility. You have some select bacteria in the United States and abroad that just doesn't have a therapy for it. Now, sometimes the body is able to fight it off because we did live before antibiotics. We had lives. We just didn't necessarily live as long, or not as many of us made it all the way to advanced age. But the idea that an antibiotic era might be coming to an end, especially if we don't really get a handle on it through antibiotic stewardship, is a problem. Now, the next thing that's coming is we've talked about antimicrobial stewardship or antibiotic stewardship. The next thing that's coming is the diagnostic stewardship, right? So with these new and rapid tests, they're also really, really sensitive. Though the analogy I like to use is that when you talk about finding a needle in a haystack, you think about these rapid diagnostic tests as a giant super magnet that can suck up any needle anywhere in that haystack, no matter what. The problem is that we are used to less sensitive tests in medicine. And we think that if we get a result back that says that there's a bacteria, that we automatically have to treat it. The problem is that if it's actually not making you sick and it just happens to be there, it's best to leave well enough alone. So using the right test for the right patient at the right time becomes diagnostic stewardship, or testing people appropriately so that you're not over-interpreting the results and saying, hey, this person's got this bug, I need to get rid of it. Well, maybe you don't. Maybe it's actually has been there for a long time, not making anybody sick, and you should leave well enough alone and not expose that patient to antibiotics.
And I think that's an absolutely great way to close this conversation, because I think the ask that we were going to have of our listeners is, we are certainly not asking you to not ask for medication, because to the point that we have been talking about just now, is it is important to get the medication when it's needed, but it's really about educating yourself and considering that relationship with your doctor as a partnership. So, we encourage our listeners, go to apic.org/antibiotics to learn the ABCs of antibiotics, antibiotic stewardship, and how to educate yourself when you're going into the doctor's office. We want to thank Marc-Oliver Wright for joining us today. Thank you, Sylvia.
Thank you, Hannah.
And we'll see you soon. Thanks for listening to the 5-Second Rule and doing your part to prevent infection, because remember, infection prevention is everybody's business. To hear more 5-Second Rule episodes and learn more about how you can help, go to apic.org/5-Second Rule. The 5-Second Rule is produced by the Association for Professionals in Infection Control and Epidemiology staff, including Hannah Andrews, Ricky Dana, Christine Miller, and Sylvia Cavedo, in partnership with Human Factor. Audio tech is Blake Alphen.